Okay.
Okay. Well, thanks, Chris.
Yeah.
Thanks, Andy. Thanks, everybody, for having us and supporting this project. This has been, and thanks to everybody who's both visiting us for the first time or listening to this online. Um, we're looking forward to starting this. When I was getting ready for this, I was looking at our folders, and even this was a project that we were working on even before we sort of formally started. But my first um, notes about this are from many, many, many years ago now. And so I'm happy that we're moving forward with it. We'll try today to cover some of the basics, knowing that not everything we can do for this registry will be able to be covered through this. And we have a plan for education that we'll talk about. And that different people at different stages and different levels of the CCRC sort of labor force will have different teaching that's sort of appropriate to what they're trying to do. Again, as Chris mentioned, this is certainly not one person project. There's been a tremendous amount of work by George, Arthur, Ryan, Usha, David before he left Columbia, and Chris and on this project, and other people who have worked on this throughout the process. You guys have probably heard my voice talking about the same updates over and over again, so I appreciate that. As we said, there are some DUA modifications that Yoon is working on that Rachel, if I'm wrong, maybe complete already between Columbia and Michigan. And then the red cap that has been designed for a little while, all they have to do is to upload it. Although we did receive a couple comments from the data champions group that we can edit, and I'll contact them to make sure that those suggestions are incorporated. And I'll go through some of those suggestions as we're going through the PDF today. There are some tasks that people are going to have to do, and I want to just cover these at the front. So before you get lulled into sleepiness by my voice, you do need to identify who are the people who are going to work on this. And that should include both your site lead and the data champion and anyone else who's going to interact with the data. And you should send those emails to Rachel. The Michigan folks will release access to the red cap through that. They want to emphasize that you should regularly interact with the red cap because they have a somewhat punitive um, non-accessing process. You're not just blocked, but you're actually kicked out of the system. And so Rachel's going to send reminder emails on a regular basis to engage with the registry, which you should anyway, because there also will be some reports that we'll be able to get out of it. For your teams, please identify people who are going to be solely entering data, and then some people who might want to generate reports in the way that RedCap can for summary data, both for your site. So if there are questions about that, please refer those to Rachel. There will be specific detailed data champion education. This is a very, PVS is a technical field, and there we want their people to be starting from a good position. We've had study coordinators who are not physicians play with this, and it seems to work, but they had to have some familiarity with PVS. And so there will be definitely an important period of learning and communication with your site leads. But Ryan and George have agreed to work with the Data Champion Committee to generate some sample cases and situations that they can run through so that that onboarding process can be uniform and start in an effective way. A task in the background, again, from everybody is to identify the cohort of patients. And we'll go through the inclusion criteria to tell you exactly how far back to go. But PVS patients treated with surgery or cath dating back to an initial procedure of January 1st of 2022. And so that strategy is going to be different in every site. And we'll talk about that a little bit, but it should involve communication, certainly between your site lead and data champions and whoever's entering the data. There also will have to be DeGauss training for the people who are entering data and for both setup and training. And they can, I would refer you to George and Jeff, who have done this before and have kindly offered to be engaged with that process. Finally, this is very premature, perhaps, because it's going to take us a lot of time to enter data, but we have generated a list of projects because we've been thinking about this for many years. I think it makes sense to think about this as you're looking at this registry, as you're thinking about how it's going to be useful so that we can start working on it. So even if you're interested in participating, we have lots of projects and too many projects to have just one or even the people on this committee or people who've worked on this to be the sole authors on. But certainly new questions that are going to arise that you should think about as you're entering data and as you're taking care of these patients. And so please reach out to anyone who is involved in this process and we can continue to work on that. There is a collection of materials that should have gone to everyone on the invite list. I sent this to the Boston folks Sadly, like 2 minutes before this meeting started, so check your email now. But for everybody else, there should be these documents, a PVS2 PDF, which is a PDF of the REDCap registry itself, which I think is actually easier and less prone to like Zoom lag to review. And that's what we're going to review subsequently. Um, a .doc, a Microsoft Word document that's got that very rolls right off the tongue title of CCRC underscore PVS underscore coding narrative, which I think is actually misspelled in the title. And that is a draft of the instructions for the registry. The registry is designed to be very user-friendly in terms of being able to review it, but there are aspects of it that need some explanation, and they're included in that. I would encourage you, if you can, and you have enough screens or resources, to pull that up as certainly as you're working with the registry for the first time, but even now, or as you're doing training as a resource to take notes on, there's spaces that are left intentionally open if you have questions. There's also a CSV file of the data dictionary in case you want to download it into REDCap and play with it or do things like that. If you do that, there are additional instructions that have to be performed to install the repeating measures parts that are intrinsic to the registry that I can't encode in the data dictionary. And there is a relatively easy to follow PowerPoint presentation that I have on my computer. If you want to do that, please contact me. There are some differences between what you have in front of you with those resources and what will be on the REDCap. And those are primarily because of suggestions from the Michigan folks, as well as the restrictions on what we're going to give them and what might not be appropriate to give them. So site, there is you'll see on the sheets, there is this area to enter which site the patient's coming from. The Michigan folks will do that based on who's entering the data. And so the patients will be identified by a unique identifier that's connected to a site identifier where they're being cared for at that time. The PHI page that is included in the PDF that you have will be removed because they won't record that. But I'm going to remind you, and I'm going to say this twice, very patiently, but very firmly, that you need to maintain some way of linking your subjects to the REDCap identifier. You need to maintain a link between your subjects and the REDCap identifier. If you're using a local REDCap, then that'll be intrinsic, right? But if it's not, you will need to generate either a classic, Excel spreadsheet that has those in 2 columns or some other way. I would strongly encourage you for the use of this module and moving on into the future that you would include with your patients their PC4 identifier. Many of these patients are in either your acute care unit or your cardiac intensive care unit. And then when they have that, including that is useful. And it will be useful if we link our data to other CNU registries in the future. This is not mandated. So if you have problems with doing that or don't want to do it or don't want to communicate with your PC4 team or have other issues, we can save it for later and we can talk about it. In lieu of having that PHI, date of birth will be moved from that PHI page into the first main sheet of the registry. And that is, after talking to I did not include it initially because I didn't think it was kosher to do so. But according to PC4 and their team, they felt like, the DCC at Michigan, they thought that that was reasonable and within their constraints. And so that is included. It is not a required field. And so if your site has an issue with sharing dates with an outside REDCap, you can save this for later and we have to discuss how that's going to affect calculations and other things, but you can take it out for now and we can talk about it later. So please, we can chat about this at some point in the future.
Michael, can I add one more thing about the PC4 patient identifier? Just
Yes,
one
please.
of the subtlety. So yes, if this would be the ideal situation, not required, but definitely ideal, and there will be a place in the REDCap at Michigan for you to enter the PC4 patient identifier, because once that is linked to your site, that is actually a unique identifier. It's not trackable across sites, but at your site, that PC4 identifier is a unique identifier. That's not PHI, so we can enter it. It's possible and probably likely for many of the patients that are eligible for this registry that they do already have a PC4 identifier because they've already been admitted to your CICU. And so it would be great if you could know how to confirm that, and if they have one, to find it and use it. But there may be patients who, for whatever reason, don't have a PC4 identifier, and so you also can create a PC4 identifier. that is a step that really has to be done in coordination with your PC4 teams, because if you're creating a new identifier for a patient who might eventually get into the CICU, they need to know that that patient already exists. So if that is a process done through either Lumatics or Cardio Access, most commonly. Um, and if you have questions about any of that, just reach out to us. But there's, yeah, just two different ways to find a PC4 identifier. Either they have one or create a new one.
I will admit that I set you up to do that, and so I appreciate you doing that. I want to review with you the eligibility, inclusion, and exclusion criteria. These are included in the registry currently, and these are technical, and so they will require coordination between, your site lead or someone who is very comfortable with pulmonary vein stenosis. And so we have agreed after many, 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 many sessions discussing exactly how many lobes of lungs should be involved, that we are going to include only patients who we think have what we would call severe PVS, which is stenosis or atresia of the pulmonary veins draining greater than or equal to 2 lobes of the lung. So that can include a common pulmonary vein or 2 separate lobar pulmonary veins, an upper and a lower, upper and a middle, 2 uppers, 2 lowers. You think about any combination or permutation that you want. That does have to be confirmed by cross-sectional imaging or catheterization prior to intervention. And the intervention can be either surgery or a cath for pulmonary vein stenosis. And that intervention has to happen after January 1st of 2022 and before the patient turns 18. And so that includes both patients who have received their initial procedure before today, and then ones that subsequently happen as they move forward in time. So it does have this weird backfill and then forward filling mechanism that is similar to what we did in ductal dependent pulmonary blood flow. There are some exclusions.
Mike,
Yes.
just to confirm. So if a patient has a canal repair along with pulmonary vein stenosis, that patient would be included. So anything
Yeah.
intracardiac along with pulmonary veins will be included. It's just the
Yeah. The
total
classic
vein stenosis.
patient who has a canal repair and then develops pulmonary vein stenosis, you count them from their pulmonary vein stenosis intervention, not from some other.
So we have had a couple who have had, pulmonary vein stenosis and canal repair at their primary, as their
As long as you
primary
diagnosed it
intervention.
through something carefully, like either a CT or a cath,
That should be okay. Perfect. Thank you.
Yeah, and you'll see some of the details about cardiac operations and caths later that incorporate both what's happening in the non-PVS and in the cardiac operation space. We do want you to exclude isolated confluence obstruction, so confluence without upstream pulmonary vein stenosis after total anomalous, mixed partial anomalous pulmonary venous return repair, extrinsic compression of the pulmonary veins with no intraluminal or no stenosis of the vein itself, due to a mass or something, is excluded. Sorry, Andy, but fibrosing mediastinitis is excluded. I know that doesn't plague patients, those of us who are fortunate enough to work in the Northeast, but we do not want to make this a fibrosing mediastinitis registry. And then there's a question about this. Patients who have a previous lung transplant, who have had their pulmonary veins from a donor inserted into the body, are excluded, even if they develop pulmonary vein stenosis subsequently. And that is distinct from heart transplants, which don't normally, in fact, I think essentially never include the pulmonary veins as part of the transplant. That was a concern from the data coordinating champions, and the data champions, and I just want to make sure that's clear. Okay. How should you identify these patients? Well, each site is going to be different. There are, if you are a very large site, the hope is that you also have a group of doctors who take care of pulmonary vein stenosis patients and who keep track of your patients. And in those settings, I think it's relatively straightforward to review your list of patients and identify the patients who have been treated. At sites that have more ad hoc or sort of case-by-case treatment of pulmonary vein stenosis, one of my hopes is that you'll develop a more systematized approach to taking care of pulmonary vein stenosis patients. But if you haven't up until now, you're going to have to look back in time, several years now, to identify those cases. And you could do that manually like we did, at least we did for the ductal dependent pulmonary blood flow registry, and just look through your cath and surgical schedules. Alternatively, Andy and some of his colleagues at WashU have identified the codes in STS and impact / C3PO that identify these interventions. And that can at least give you some sense of it. I will say that when we compared those codes against ICD-9 and ICD-10 codes, it was not very effective. And it was very hard to uniquely identify them. And you had both positive, sort of false negatives and false positives that come up if you use those codes, because the codes generically include both pulmonary veins and systemic veins that are not cable veins. And that is, I think it creates, from my perspective, I think it would create more work than might be useful in that way. Andy, do you have comments about that before I move on?
No, we can share what we have, but yeah, there's no perfect way to do it easily.
Yeah, I think that's true. I will say that my hope is that places that have a large volume have a system to track these patients, and those that have a smaller volume, it'll be less difficult. Chris, you have your hand raised. I apologize.
Yeah, no, you're good. I was just going to say what's really fascinating is that in Impact plus C3PO, the codes are incredibly specific. If you balloon angioplasty to the left upper,
Yes.
that's separate from a stent to the left upper, which is separate from a balloon angioplasty to the left lower. It's like incredible. And then in ICD-10, it's like
Yeah.
stent vein. What? It's like it's crazy. So you're right. I mean, the C3P code and Impact codes are really good. The CPT codes, in other words, are really good.
And in at least our review, when we were trying to recapitulate some of the work at WashU, we found that some of the surgical codes, especially in regards to like venous baffles and stuff, get miscoded frequently. And so hopefully they're sensitive, and so you'll get a larger number of operations than you plausibly got for primary pulmonary vein stenosis. Admittedly, we don't do a lot of pulmonary vein surgery, and so that might also have contributed to that because they're just not codes that are used all that often. Uh, a suggestion that I think would require some work, but Jeff has done this in the past with ductal-dependent pulmonary blood flow, is that as you're working with this registry, there are some things that incorporating certain elements into your clinical documentation would improve this a lot. And so those of you who have control over how you code or how you record caths and things like that would be really helpful as you think about this. And if people want to work on templating it, I think that'd be a good use of people's time and effort as they move forward. So now I'm going to pause for a second, and we're going to eventually start talking about the actual registry itself, which is a little bit tedious, but important for us to review. Are there questions before I proceed?
Mike?
Hi, Ravi. How are you?
Good. How are you? I just had a question about, you at the beginning you said you have identified specific studies that this registry that we can use this registry for. In addition to that, if individual institutions have additional studies that we would like to develop, I presume that's okay, and we would submit it to the CCRC for review.
That's what I'm saying. Yeah, if you have ideas for a study that you would want to perform, whether that is using this data or adding data to it, that's something to start thinking about and talking to it's the new projects team, which I think is Author, or
Okay.
talking to the people who are on the PVS team to start talking about the practicalities of it. Happy to do it. Okay.
Thank you.
Anyone else before I keep moving? Okay, so some orientation.
Sorry, one second. I was looking for my mute button there. Yeah, one thing we'll talk about certainly in the spring meeting also, Ravi, to that point is, we'll probably try to generate some robust research proposals and then start the SPF project for the use. So like Michael said earlier, when you started off, Michael, even the ideas that have been thought of, there's going to be plenty here for people to sort of engage in. And so we can sort of iron some of those projects out and get them to take some shape this spring.
Sure.
And the reason I asked is Dr. and I have been talking about this extensively at TCH. We're excited about getting this started, and we have more ideas and projects we can do at this point.
Great. So again, to start to orient people to this, what is really true about patients with pulmonary vein stenosis is that they have some baseline characteristics, and then they undergo a series of events that happen over and over and over again, intensively, especially in the first year of treatment. And so this registry contains a relatively small number of total sheets. You're going to work on a relatively small number, but a large number of them are repeated. And so I'm going to try to provide some orientation to that before we start working through the individual sheets. The individual sheets are intended to be readable and legible to a person who's not a PVS interventional cardiologist or surgeon. That is not always perfectly true, but we've done our best to do that. I would recommend having a copy of that, like not particularly long, but coding narrative in front of you while you're navigating the registry for the first time or even subsequently, because it does provide clarifying information for situations that may not arise every time, as well as orientation to people as you're doing this process once, twice, 100 times. The 10,000-foot view of the registry is this is as much of the registry as I could encapsulate on a single slide to make it so that you can understand how you navigate it for the first time. For outside of REDCap, you're going to ensure that a subject or many subjects are eligible. You're going to find a way to store their PHI that works for your center and that is consonant with being able to store their REDCap identifier. You're going to then go into REDCap using the login that Michigan's giving you. And for each patient, for one time, you're going to enter their demographics, their baseline clinical data, and initial evaluation of pulmonary veins at the time of their initial evaluation, at the time of their initial evaluation, at the time of their initial evaluation or therapy, which means they're in the cath lab or right before their operation. And so that is the time frame for that time independent single piece of information. And those are each individual sheets that we'll go through in a moment. But it is, even during the backfill, unless there was something that was congenital, a genetic syndrome that took a while to be identified, those are all at that point looking backwards. That was a question people had. I just want to make sure that's completely clear before we move on. Then these patients will undergo multiple surgeries, multiple catheterizations. Each time a patient undergoes a surgery, there is both a patient level description of the surgery and then a description of every vein that exists in their body at that time, even if it wasn't intervened upon at that surgery. And that's important because we are tracking both patient and vein level outcomes. There may not be a lot done there. It may just be that there's no disease there. And it's coded in this sort of weird way for human beings because it saves a lot of space from a data perspective, which was the request of the DCC, our Data Coordinating Center, so that we would limit the number of variables that were incorporated. We'll see how that is instantiated or how it's done once we go through the registry. In addition, I'm going to skip to the bottom of the page because it makes more sense. These patients undergo imaging studies, as you know. They are admitted to the hospital, and sometimes bad things happen to them. At some cadence, whether that's every month or whether that's every year or whether it's every half year, you should go back, and the imaging data initially was just whether they got an echo, whether they got a CT or MRI, whether they got a lung perfusion scan, and the date that it happened so that we can count resources as they're used and have some information about those cadences so that if we end up going back and looking for information, it's identifiable. At the request of the EC, there is a request to add some radiation data to the radiation incurring studies, and that is incorporated at each of those. Hospitalizations, even short stays, even short stays, even short stays, even overnight admissions that aren't 24 hours. We want you to tell whether they're admitted to the hospital or not. So if you have a cath, you're admitted overnight and discharged 12 hours later, that still gets counted. It incorporates both ICU stays as well as recovery unit stays, PACU stays, NICU stays, and you name it, it's on there. If it's an ICU, you count it as one way. If it's a non-ICU, you count it the other way. Outcomes, if somebody dies, undergoes either a heart or lung transplant or both, or has a stroke or is cannulated onto ECMO, we want you to count that. Doesn't matter presumably it's in a hospitalization, but even if it's not, and there is a date associated with each of those. To clarify, I think there was a question about time frame from the data champions. It's after they're identified, right? Not if they had a transplant before they were identified, and then subsequently moving forward. And you can record them on one sheet for if each of those events happened at one time. But if they have subsequent events, they have strokes repeatedly or ECMO more than once, record it over and over again. Johnny, you have a question.
Yeah, you just sort of answered it. It was going to say like there's dichotomous outcomes there with like death, transplant, lung transplant, but ECMO and stroke, the same patient could stay in the registry.
Yes.
And
It's just in
what?
one sheet so that it's easier to make it recursive, but you can record each of those separately, and they
Gotcha.
can be recorded. You could record a stroke, an ECMO, a transplant, and they can accumulate forever. Okay.
Did you
Yeah,
see did you see Usha's question?
I did not. I'm sorry, I can't see the chat.
In the chat, Usha asks, what about infections in the setting of like sirolimus, for example, or something like that?
It is an important question that we've talked about periodically throughout this, and it's a deciding which ones to count. Counting every bronchiolitis or every admission was really challenging, and as of right now, which is I think no change is locked, sent to Michigan already. We're not going to count that. I do think that there is room in the future to have whether it's a case control study or something of people who have been on sirolimus who develop either counts of infections or more importantly, we've had a couple of patients develop what would be pretty clearly opportunistic infections and talking about that. But for the purposes of this, the number of events that are hard to quantify as infection or PVS exacerbation or BPD exacerbation or chronic lung disease exacerbation made that prohibitive. And so it did not make the sort of final cut in regards to what data we're collecting. If you die of a respiratory infection or something like that, that will be captured, but not if you're well or hospitalized for that reason. The last part, which I want to make sure we cover before we sort of get into the weeds again, is that we recognize that it is important to track these patients and that we're going to track these patients forward in time, either from when they were initially entered in the registry looking back or prospectively, and that we didn't have, in addition to interventions, we would want to know how they're doing. And so there is an annual form that is tracked from their initial intervention. So not from their date of birth, not from some other date, from that initial date, 365 days forward, recursively, that tracks where they're living, what's going on, and whether or not we know their veins are open in case they've had, they've gone into a different sort of care pathway that we're not treating them anymore. In addition, I think there is an interest in without getting into extraordinarily and excruciating detail, drug levels, et cetera, knowing how different centers are treating PVS in terms of medications. And so there is an annual medication form for the preceding 365 days, again, starting the timer when they were initially treated. And there is a definition for how long you have to be treated to consider a medication as part of that year. And it's based on the oncology literature. And so I will get to that in a second. But I think it's an important thing, especially as therapies evolve and as different groups, go from using no medicines to sirolimus to other things to be able to track that. And there has to be some capacity to expand that as you move forward in time. So there are some hard to track at this point new medications that are listed as unlisted right now because they don't exist yet. But that again is an annual thing. So you can incorporate that at an annual cadence moving forward. Questions before I move on to some details? Okay, so I'm going to stop sharing this and open up the PVS PDF now and show and go through some of the questions people had and show you some of the details of what we have. Okay, so what I hope you see is the PVS preview. I'm going to make it a little bit smaller, even though that'll be individually smaller to see, but you'll be able to see more of the screen. Thumbs up from Andy or Chris, because I can see you guys, whether you can see that. Thank you. So this inclusion criteria sheet is going to be edited. The part that is the site is going to be taken off. That will be incorporated again as by Michigan. And then I would recommend that this is a really important thing to know, and we've had this issue with delta impediment by blood flow. We really want to make sure that we're including only the patients that we care about in the registry. So this is the kind of thing that you really want to work very closely with your site lead and data champions to make sure that that list is correct. And this is listed as a checklist. It's in, for our site, we go through this for every site, for every ductal dependent blood flow patient. And we'll do this for PVS as well. And I'd recommend you do the same, even if you have a large number of patients. These are the exclusion criteria. The protected PHI sheet, which I have included in case you want to use it as a template for your own records. I think it might be a good idea to do that, but that's up to you guys, is here, but it will not be in the red cap. This is a sheet that, or part of the thing that Andy wanted included for people who are going to use this sheet, and for people who might want to include patients who are not included currently, who they might want to track. And so this is included here for that reason. Demographics are relatively self-explanatory. I will stress again that this is an opportunity to enter the PC4 ID so that this can be linked moving forward. Andy did a very good job explaining where those things are available or how to do that process. If you have questions about that, that can be included. Sex/gender, there was a question about whether it should be sex assigned at birth. This is obviously a complicated issue. I think you should describe patients as their parents describe them at this point, because these are all less than 18. And so if there are questions about that, we can deal with it, but it is listed the way it is for that reason. Race, ethnicity, and insurance plan are listed as they are in the same way that they're listed in PC4, but to avoid having to link things to PC4, they're listed that way. There will be DeGauss training, or there will need to be DeGauss training for each site in terms of both setup and use for this next section.
Michael, I think the distance from center doesn't come from DeGauss, right? That's a Google
Yeah,
Maps.
that's a Google Map.
function. Yeah.
Yeah.
Okay.
Oh yeah, so I'll fix that. Sorry. All right. Baseline clinical data, whether they have a genetic syndrome, from these genetic syndromes, if they have another syndrome, what it is. There was a question about whether we want chromosomal anomalies listed or just genetic syndromes. I would say that if it's an eponym, to include it, but that if it's a variant of unknown significance, that I would not. I've looked through the PC4 other syndromes and diagnoses, and it can get very, 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 very messy. And I think that it is primarily more important to capture these named syndromes that are more common. The estimated gestational age in weeks, and if everyone has a day and a week, you can just divide the days so that 34 and 1/7 is 34 plus 1 divided by 7, rather than trying to enter something crazier than that. It's listed as an integer there. Birth weight in grams is all clear. Intrauterine growth restriction, which some people would abbreviate IUGR. Whether they've had NEC before this one time that you are entering their data and before their initial intervention. So all of these things are in reference to the time at which they're undergoing their initial intervention, as per that first thing. That was a question that people raised. That is also true about these airway conditions. They can have other airway and lung conditions later. That is coded elsewhere. So again, all of these first 3 sheets are in relation to the time at which their first intervention was performed. Hence the current, hence the significant previous, etc. There was a question about whether a small ASD or PFO, how to classify that. To me, that's sort of, if you would call it a real ASD, it's a real ASD, and but it's the quibbling about what a PFO versus ASD is, which is why that is intended to be different. But hopefully that shouldn't be too complicated. I think that if your site, you should talk to your site lead if there's a question about that, and it shouldn't create too much of a problem. I'm looking through all these to make sure. There's a question about where high flow fits in supplemental oxygen. Supplemental oxygen should be in that portion and not CPAP. Sorry, Ryan, you had a question?
Yeah, I mean, we could go through some of these specifics. I'm just making mental notes here, but that, this page is trying to establish what are the known risk factors for the generating of PVS. And so, like a small ASD versus PFO may not be a significant, that's the right chance. to me, that's would not be a risk factor for PVS. So.
Okay. And then in this initial evaluation of pulmonary veins, again, we'll go through the details with you subsequently. It should be at the initial evaluation by tomographic evaluation or by catheterization. So if they get a surgery as their first intervention, you're going to use the combination of whatever they've had up until that point to make these judgments. There is a lot of words here to try to make this as clear as is humanly possible. But again, it is in reference to their condition before that first intervention with the most recent data that you have available. There was a request here to provide illustrations of pulmonary veins in the teaching materials. And that is a good and convenient reminder that you should look at the teaching materials when you're reviewing this, because there are pictures of all the pulmonary veins in those teaching materials in the coding narrative. And so that's there. You can look at those there, and it describes the most common variations of what the right upper and right middle come in together, and then subsequent other common pulmonary veins.
Hey, Michael, just to be respectful of people's time, if you want to hit like the, a few other, I know there's so much here and it's really all important.
Yep.
And probably we'll need to schedule a separate training for everybody who's going to be involved in data entry. But if there are other important things.
One other thing I think is important to cover. I think the other ones are relatively self-explanatory, but the one thing I do want to make sure that we cover for real is when a patient undergoes a intervention, there is a description of what happens to them as a patient, which is here, patient level intervention on page 12. And then there is a specific description of surgery for each vein. And this is going to be somewhat annoying, but for most people who have 5 veins, you're going to enter the vein surgery part 5 times. And this was at the request of the DCC so that we don't have to create a variable for each vein or each theoretically possible vein, which is even more for each one of these variables. And so that is a somewhat annoying thing. And I just want to emphasize that this is very clear in the coding narrative, and it's very clear here. We just have to go through that over and over again. And so that field, that set of fields, is going to get populated fairly. There's going to be a lot of entries into it, right? Because every cath is going to have 5 entries in this section, or 4 or 3, depending on the patient. And this includes once they have had, if somebody has atresia or something of that vein. Okay. Everything else, I think we can cover in the future, and I don't want to take too much of people's time. I do want to also leave a little bit of time right now if there are big picture questions, while also offering it if it's a site-specific question or a question about how you want to implement this at your site. That there'll be meetings with the data champions, but also I'm happy to answer them separately. But I don't want to answer what it's like for you at your site right now, unless it's a question that'll be helpful to everybody.
Michael, just show the annual follow-up forms. I think that just is helpful to see both in terms of current status and then medication exposures in the preceding year, just to show how that lays out. Yeah.
So again, this annual form refers to the year that extends from that last visit or from that first intervention moving forward in time. And then there are questions about whether they've largely been in this condition in terms of respiratory support at their last contact or follow-up with a doctor. And which veins were known to be present at that time in case someone is, just as not getting caths every year. And there was a question about where they live in terms of at home, in a facility, they've been an inpatient for a year, which would be, or the majority of the year, which would be sad. The medications, again, are for that year, 1, 2, 3, 4, 5, extending out from when their initial intervention was. Again, start with the year they entered the registry and count from there. And then what their most recent date that medications were documented, some visit with a medical provider. They're divided again by general classes, which I think from people as you're going through this is going to become very common, but anti-platelet agents or anticoagulants. Some people still use angiotensin receptor blockers, so we included a section on that. mTOR inhibitors, which, I'm not sure what's less informative, calling it mTOR or the mammalian target of rapamycin, but that's what that is. It's sirolimus, and then these biologic agents, and these are all listed as requested as the generic name first, and then in parentheses the trade name, and that was a request. Also, how we did it. And and unfortunately, there are, especially for PDE5 inhibitors, proliferation of different trade names, and so some of them are not included. Again, this is something that at your institution you're going to, at least if You're like us, we use the same drugs over and over and over again. And so it should be relatively clear. We did have to include these other mTOR, other agents, because there is the potential that there are going to be new formulations of medications. The Petit-Callahan polypill that includes imatinib, aspirin, Plavix, and sirolimus plus sildenafil. When that comes out, we're going to have to find some way to code that.
I'm taking that already. Working well.
I was going to say, yeah.
Prophylactic.
3 times a day and before lunch. Got it.
We should all be on that, honestly.
It's true.
Okay.
I do.
But yeah, Andy, I think that's helpful. Again, if there are questions about the common regimens that you use at your institution, that is a great conversation to have with your site lead. And typically these are repeated over and over again. If every time we write a PVS consult note, they basically, for us, that's very similar, or one of two patterns.
Michael, can I ask a quick question about what you said before about the different veins? Were you meaning that if a patient has 4 veins and you do a cath and you intervene on 2 of them, you'll enter 2 sort of intervention sheets and then you'll enter the other 2 veins as like not intervened?
Yes.
During that cath, is that what you mean?
Right. You're going to enter something under vein for each vein that exists. And there is and I apologize for going through this quickly, there is an entry that says we didn't touch it, it didn't have disease. Yeah. Thank you for asking that. That's clarifying. All right. Well, I think we're cut off, and you should all go back and see your families or finish your work days. If there are other questions, please reach out to us. And I know that the people who are better at explaining things are going to work really hard to make sure this is implementable. For the people on the Data Champions Committee who sent me comments for the units and things like that, those will be incorporated into the stuff that goes to Michigan. It's already been with them, but I don't think that he started it. So I'm going to do my best to make sure that he has a good copy tomorrow.